Device Nation here in New Orleans Academy 2026 Docs and Reps booth crawl. We got Dr. Brian Fuller, Dr. Blackwood, Dr. Vendasa, James Kim stepping in with Overture, Chris Cosentino, Val, and Jeff Adams. Chad Raines, we got quite a cast here assembled at the Overture Orthopedics booth, and we're so thankful that you invited us behind the booth to see this. It's been catching my eye for days. I've been super excited to kind of finish up here and hear what all the buzz is about. So congratulations. A lot of people have been visiting your booth. Walk us through it. Would love to know the backstory, how you got it started, and where you are today.
Absolutely. We all have Mr. Kim kind of explain the backstory of the company, and then I'll kind of take over from there, if that's okay.
So this device here was designed and created for patients who are between the ages of, we'll call it 38 and 65. Right, you have patients who go through that entire spectrum of knee care, and they'll get their pain management, they'll go ahead and they'll get even an osteochondral allograft, and then at some point they need to move on to a partial or total knee replacement. So this here is filling that gap, because not all patients are ready to get that partial or that total knee replacement. But also their knees are now catabolic. So any of the biology, any of those options that are out there, those just aren't going to be an effective option. So this small group of patients between the ages of 35 and 65, it's very different than when we were all growing up with our parents, right? Our parents at 50 were not doing half marathons or anything like that. So I think with the changing patient population, you also need to have new medical technologies, and that's really where we're coming into play. And I'm going to hand it over to Chad. He's going to share with you some details about the implant, some details about the surgical technique, and some details about the patient.
Yeah, thanks, James. Appreciate it. So what I got excited about, and I've been in this industry almost 30 years now, and been in robotics, been in reconstructive surgery, biologics, but when James called me and said, do you want to be a part of this? I said, well, let me look at it and see. Absolutely. When I saw it, I saw the market need. There is a gap in treatment for patients like this that's not quite ready for a uni or total, but not the best candidates for biologics. So we fit that gap. And so what we've done, we've created these implants, and these are 100% titanium. Okay. The back is 3D printed titanium. It's 80% porous. The coating is a titanium nitride, which is like a ceramic. Okay, so it's very, very slick. And then we have tibial components. We've gone industry standard polyethylene, ultra high molecular weight with vitamin E, and it also has the same base plate on the back. So a little bit of bone cement around the stem or around the post, just an initial fixation, and then bone growth for the rest of it. Our average age of patients has been about 45 years old. They are doing really well. It's a very small arthrotomy in the knee. This is cleared to be used with a femur and a tibia together. So we have both components to articulate with one another. So if you have those kissing lesions in the knee for the femur and tibia, they basically point themselves out. So you cover the graft, or the defect, with our sizer, you pin it, you ream it, and you fill the defect. Very simple procedure, very easy to do. This is off the shelf. This is not customized. It's not patient specific. We have 3 different sizes of oblongs. We have 3 different sizes of the rounds and 3 different sizes for the tibia. So those sizes, radius of curvature of the femurs, correspond to the averages that our engineers figured out what's the best for the knee coverage. Right? Most of the defects are distal for the femur in the middle, and most of them are slightly anterior central for the tibia. So we've had really good results with this so far. We've done about 175 cases over the last 2 years, and we're collecting data as we go. Would you like to see it?
Sure.
All right, so I think I have a volunteer here, Dr.
Yes, we do.
Desai is going to do this, so I'm just going to walk you through this, and this is going to see how easy it is, okay? So let me get you a fresh specimen here. Now the first thing you want to do is go ahead, and we have sizers that are available, and these are disposable instruments. So they come in a kit, they're single use, throw them away afterwards. So you have a defect, you want to size your defect. And you want the sizer to totally encompass and slightly overlap the defect, because you want to make sure you get it all out. Kind of like a dentist reaming out the cavity for a tooth and then filling it with something. That's what we're doing here. Once that's sized, then we have our pin guide. Okay, so go ahead and take the pin guide. Go ahead and just put it in. What you want to do is you want to make sure that it touches all the way around on the cartilage. So make sure you have full contact with it. Okay. Now you want to go ahead and drive your pin. And there's a little notch, right, and you'll be able to see it's right about there. So how about how deep you want to go? Can you see it?
Yeah.
Okay.
Kind of.
Kind of like,
I see it now.
okay,
Just to the line?
to the line. Perfect. Go ahead and take your sizer off. Now the next thing is going to be your primary reamer. This primary reamer has blades, 6 blades on it, and a hard stop. So your depth is already dictated by the size that you've chosen to put on. Oh, thank you. So you're just going to bring them over the pin, and you want to go all the way to the hard stop. Beautiful. I'm going to blow this out. Now we do have a secondary reamer that's done by hand. The secondary reamer has a topography and a geometry that matches the shape of the implant you're going to put in. So it's like a secondary check. So what you're going to do is slide it over the pin, and what you want the edges of this to be recessed about 1/2 millimeter below the surface of the cartilage. If it's there already, perfect. There's no more you have to do. If you need to go any deeper, then you can ream a little bit more by hand.
So it's kind of like a trial / reamer.
It's kind of like a trial / reamer, correct?
Got it. Yeah, feels good.
Perfect. So go ahead and take that off. Take your pin out. Perfect. And the next step, Kevin, do you mind changing that out for him? You don't mind? On the striker equipment. So the next step is going to be to ream for your peg. Now this is a 5 millimeter reamer. It's going to give you 1/2 millimeter cement mantle all the way around. Okay. So what you're going to do is once this is on here, go ahead. Go ahead and drill. There's a little stem on the end of it that guides your trajectory, and it goes into the pinhole. And you just go ahead and drill all the way down to the shoulder.
What's the depth of this?
So it is size dependent. So you're looking at about a 7 to 8 millimeter, depending on the size, thickness of the implant. The stems themselves are 7 millimeters long.
And what's the total length of this?
That's going to be about 15 millimeters.
15 millimeters
15
deep.
millimeters deep.
Okay.
So we do have a trial. So you can have the option to put a trial in, just to make sure that you're where you want to be, that it's recessed 1/2
Does it
millimeter.
have to be any particular?
It doesn't have to be in any particular orientation. And actually, that's perfect, actually. You're about where you need to be.
Okay.
So you can take our remover, put it in, clock it about a 1/4 turn and pull. Beautiful. And now you're ready for, you put your 1/2 cc of cement in the peg hole only,
Okay.
and now you're ready for your implant.
So do most people just do it by hand?
Yeah.
They kind of make a little cigar or something and stick it in there? Or?
No, actually, you just put you put it in like a 5 milliliter syringe,
Okay.
and they just push it in with a syringe.
Okay. So not just the stem, but the entire.
No, just the stem.
So you need a syringe to get it into the hole.
Into the hole.
Okay, got it.
The rest of this is just subchondral bone, so you get your bony ingrowth
That's
for your
okay.
implant. And so you just put it in by hand, match it up, push it in. And then we, of course, have an impactor with a mallet, so you would impact it to your final seating. I don't have a mallet, unfortunately.
Got it.
But, and that's it. Now you've actually saved the patient their meniscus. You've saved their collateral ligaments, their cruciate ligaments. You've saved the rest of the good cartilage that doesn't need to go.
Okay.
So it's going to feel a lot more natural to them, and you've probably extended the time that they have to have a uni or a total. What we're hoping for is 5 to 7 years. We're keeping that data as we go, so we can prove that.
Got it. Now, if I go in crooked, I go in cockeyed, or because life doesn't go perfect every single time, what's the game plan if I need to get this out?
So if you need to take it out, we do have these little extractors. That's if you're going to revise it. But to take it out, you would need to get like one of your freers and just kind of lever it
Pry
out
it
slightly,
open?
yeah.
Okay.
Or if you didn't want to risk getting the cartilage damage, what we've done in the past, you take your pin, you come underneath it, and then you can push it out from underneath.
Oh, interesting.
Yeah.
Okay.
That's cool.
Got it.
You said it's FDA approved for femur and tibia, so you have to put both implants?
So it's
or-
FDA cleared for femur and tibia, correct?
Or
And.
Got it. And what's the billing code?
27446 is the CPT code.
Partial knee replacement.
Partial uni. So that was a predicate that it was approved on, or cleared.
How is everyone accessing the tibia to do an inlay like that? Because that's not very easy to access like that.
No, it's not. As a matter of fact, so you do have to make a little bit of a longer arthrotomy.
Sure.
And you have to detach the anterior horn of the meniscus and reflect it in order to get access to that.
Okay. And then how about mobilizing the tibia anteriorly enough?
So you have to have a pickle fork retractor.
And they're able to get that?
Get it out. And the key is, if you can get it out a little
The
bit.
ACL still there?
ACL still intact. So you can only get it out so much, but
Right.
you have to rotate it as well.
Okay.
And our instrumentation for the tibia are angled and notched. So whenever you the femurs here, you miss the femur when you put the guides in and the implant and the reamers. It has a little notch cut out in the back.
Okay.
So you can miss it and still get to the access. And then they're all angled 10 degrees anteriorly. So you can get better access.
Do you have that? Or?
I do, yeah, I do have that. So these are our tibial instruments. So that's the tibial reamer. You see the notch cut out for the back. So you can slide and access over if you can't get the femur all the way out of the way.
Got it. Okay.
And all of our hand reamers also notched for the same purpose.
So you have to spin, right? Do you have to spin the reamer?
You
so
do.
If the femur, so if it's like that, how?
So that's to get it down past it. And when you spin it, you just have to make sure that you're not cutting into the part of the femur.
Okay, so
you have
once
to
it's
get out.
below, then it's clearing the condyle.
It's clearing the condyle.
Okay, so you really have to make sure you're okay.
That's correct. Yeah.
Not much further.
Is this all disposable instruments?
These are single-use instruments. Comes in a kit. They're size-specific instruments. So whatever size you choose from this, which is its own kit, get the size, and then once you have your size established, you tell the rep, hey, pull this size kit. You bring that in. So that's allowed us to really minimize the amount of instruments on the back table. And the way the kits are set up, they're set up in order of use from left to right for the scrub tech. So they know which instrument comes next without having to dig for them. But
Go ahead.
oh, I'm sorry, this is just the pin guide. You can see the angle of the pin guide. And it's kind of angled anteriorly so you can get in there. Yeah, Kevin, go ahead.
Great job on the instrument.
Oh,
I mean, that's
we've been proud of it.
I mean, that's easily figure outable for anybody.
We wanted to make it intuitive, easy to use. Surgeons can get in and get out. Their time's valuable too. So we want to make it quick.
Yeah. What do y'all think? What do the rep side of the equation think? Think you could sell something like that?
Slick. I mean, certainly if you're a young patient, it's what you would want, right?
Yeah.
Right.
So I think it's interesting.
Young and active, get them back to activity.
Yeah.
With all of as much of their natural tissues as possible.
Yep.
I think this is super cool, Chad. I've been in my share of totals where the defect was contained to that, right? And having something that could preserve the other two compartments and just kick the can down the road a little bit, right? Especially, like you said, in that active situation. Does every tibia match to a definitive femur, or can you go one up, one down?
They're all compatible with each other. So
Okay.
that's a
Anything works.
great question. Yeah. You can use any tibia with any femur.
I think it's awesome.
Yeah.
All right, and I think a lot of people in the Device Nation audience are thinking the same thing right now. Chad, for the consumers of this content today that are thinking, I want to learn more about this product, whether the surgeon or potential representation, how do they connect with you guys?
Well, there's a couple of ways. We have a website. That's OvertureOrtho.com. So it has our office information on there. You can contact us directly at the office. It also has all of our literature on there, case studies, surgical techniques, get on there as well. Once you contact the office, they can get a hold of myself or James, and we'll be happy to get back to our customer base.
Nickel free?
Nickel free, no nickel, no cobalt chrome.
You make it out of shiny gold, right? It's just going to pull people in.
Yeah, it has. It's like fishing. It's brought people into, like, what is this gold thing? And that's just, it's innate color. Titanium nitride is just gold. So.
Yeah. Great job, James. Great job, Chad. Thank you so much.
Thank you. Appreciate you.
What a privilege to be invited behind your booth.
Yeah, of course. Thank you.